The flip side is you'll never see an editorial. You'll see letters to the editor that patients should not engage in these, or physicians should not engage in spirituality, but you'll never see a physician statement from any organization saying that physicians should ignore, patient spirituality. Let's move on to physician prayer. This is a little trickier and response rates are a little lower. But generally speaking, you can get rates from 5% to 95%. Actually, one of the ones that I found interesting was 96% of patients accepted prayer prior to an ophthalmologic surgery. The prayer was offered, I think, in pre-op or in the operating room. And it was two physicians in the South who do this as a routine part of their practice. They decided to go ahead and get some data on their own practice. These are private practice physicians who got their article published, sort of put themselves out there. So now everybody in the world knows that these two guys pray with every patient before they do eye surgery. But also, to their credit, now there's an article in the literature saying how the vast majority of the patients want it. Now, again, there's selection bias issues. Obviously, in this practice, people probably know that, and it probably tends to attract Christian patients who want that. Okay, so the generalizability of this article is going to be a little limited. It tended to be in a predominantly Christian community. So, for example, if you're going to go to a fairly a-religious community, or an Orthodox Jewish community, or an Islamic community, like I grew up somewhat near Detroit, you might get different response rates. But generally speaking, again, the response rate is never 0. It's never 100%. It's almost always someplace in between. And again, the sicker you are, the more likely the person's going to want this. Again, if it's non-contextualized, it's going to be lower. So if you take a well person sitting in the waiting room because they have a cold, or maybe they're just a young person with no health complaints, just there for a yearly physical, that person may say no. But once you start talking about more severe illness, or you talk about end-of-life issues, the response rates for prayer go up. Again, in Time magazine, they had a general survey that said 64% of Americans think that physicians should join patients in prayer when asked. So if the patient asks you, patients are expecting you to respond affirmatively. Again, there are articles about, in terms of the ethics of prayer. If a patient asks, then you will never find an ethical statement by an organization saying that you should not respond affirmatively. Now, it says you should only respond with prayer if you feel comfortable praying. If you don't feel comfortable praying, then you should defer to the chaplain. But it is within current U.S. medical ethics that if a patient asks you to pray with them, that you can respond affirmatively. There is a study looking at an interventional trial. So again, looking at the literature, it's one thing to hand out a survey saying, if this were to happen, how would you feel about it? It's another thing to actually do the intervention. So when the intervention was actually done, when patients were actually offered prayer, instead of given a survey about being offered prayer, it actually did increase patient satisfaction. Okay. So there's actually a lot of good articles about tools, and I think these are useful. A spiritual screening question is a single question that you can get a sense for whether or not it's worth doing some more questions. Okay? And at Penn, the spiritual screening question that is all physicians are supposed to ask at every encounter is, should we be aware of any cultural or religious beliefs that may affect your health care? If a person says yes, then that prompts you to do a spiritual history. If a patient says no, then that's a negative spiritual screening question response. So again, a spiritual screening question is a single question that you can ask to get some sort of answer. And then I have a couple of examples of spiritual history tools. The first is in the Journal of Palliative Medicine. What is your faith or belief? How is it important in your life? Are you part of a spiritual religious community? How would you like me to address these issues? The American College of Physicians, their spiritual screening, or their spiritual history questions. Is faith or religion or spirituality important to you in this illness? Has faith been important to you at other times in your life? Do you have someone to talk to about religious matters? Would you like to explore religious matters with someone? So even apart from the fact that this is recommended in a journal, and it doesn't come from a class on evangelism, it still isn't a bad place for a Christian student or healthcare provider to start when it comes to engaging patients on a spiritual level. I mean, you might get some better advice from some of the ministers here, but I mean, I really think that that's not a bad place to start. You can take a look at some of the other ones. So why shouldn't physicians engage patients on a spiritual level? The arguments that you'll find in the literature is that there's no evidence that leads to better health outcomes. I don't really care, because that doesn't really matter to me a whole lot. I mean, the outcome that matters most, really, is salvation and a relationship with Jesus Christ. That's not measured in these articles. And so the other health, God just doesn't promise that we'll be healthy. It's just not in the Bible. Another is that the job belongs to the chaplain, not the physician. But those tend to be people who equate engaging patients on a spiritual level almost like engaging patients in a sexual relationship. And you'll see that. You'll see that, physicians should engage patients on every type of way that the patient wants them to. A physician should not be the patient's drug dealer. And you'll see people talking about spirituality with a loose prescription of opioids. Like prayer is that dangerous that if you just hand out prayer, loosely, it's like handing out prescriptions for narcotics. Or that engaging patients on a spiritual level is like entering a sexual relationship with a patient. That's what some of the counter arguments are. There's some people who are really upset about this. The focus should be on any coping mechanism, not just religious coping mechanisms. But the reality is that there's a gap in a physician assessment of religious coping mechanisms and an underutilization of it. These studies are biased. The goal is to secularize religious belief. It can lead to abuse and proselytizing. Although there's one really great letter to the editor about why it should be okay to try to convert our patients. It trivializes religion, and to this I actually completely agree. I have no desire to see the sum total of religion being measured by health outcomes. I mean, that just isn't the key. And trying to reduce religion to better health outcomes, actually this is where I agree with the critics. And it can undermine chaplains. It doesn't have to be that way. I work with my chaplain all the time for my patients. At the end, I have a bibliography. And there's actually, obviously, many more articles in this, but this is a good place to start if you guys want to read more on this. So I hope I can take a couple questions. I talked more than I thought I would. But again, your courage and faith to engage patients on a spiritual level doesn't come from anything in here. God is the one who gives you faith. He's the one who gives you courage. He's the one who gives you opportunities and makes those opportunities effective. The way you deal in a hostile environment, your best solutions are also going to be found in Scripture. To be kind to the people around you, to be responsible, to do your work, do it well, be a good learner, be a good part of your team, and win people over by your behaviors. This talk is really very narrow. It's if somebody asks you to justify engaging patients on a spiritual level, and they want to do so from the perspective of literature, or they make some offhanded comment about how it's unethical for patients to do so. This will at least give you the starting point of sort of explaining yourself. Second, somebody challenged me when I was in residency or medical school, asked me, why don't I ever talk about trying to witness to the people above me or to my peers? And that's challenging. And this may be a starting point where you can give a talk on something that is medically, scientifically sound, and then talk about yourself. If God gives you the opportunity to do so, and the courage and strength to do so, then maybe this would be a tool. This is really just a tool, and maybe you'll find it useful.